federally qualified health centers. So I'm gonna try to mainly use the physician and use the term physician. And it's actually important that these claim forms be signed by a physician, even if the actual exam is done by a nurse practitioner or a physician assistant. The actual exam by the physician is less detailed and less complex than the black lung exams, federal black lung exams that Dr. Wernz does and is so experienced with. We got another person here, Debbie Wills from Cedar Grove. Welcome, Debbie. And Debbie, like Susie, is a veteran of advocating for minors with these exams. The other thing I want to say is that applying for federal black lung benefits is the same procedure all over the United States. But applying for state black, because it's under federal law, it's under the federal black lung law of 1969. Applying for state benefits in Pennsylvania, where Aaron Erb and Benedict Kane are, or in Virginia, or in Kentucky, or in Ohio, the laws are different, and the forms are different. So it's important that you know what the rules are for your state. But and we're going to be kind of focusing on the exact procedure that we have to follow in West Virginia so that minors can be successful in getting benefits to which they're entitled. But it raises, I think, some interesting questions that apply to all states and actually for all medicine, which has to do with the advocacy role of the physician. And when, as physicians, when we are doing exams like these, we have to balance our role of being an advocate for our patients and our role as a clinician maintaining objectivity and putting it down on paper like it is. And personally, I've found that really challenging over the years. And that applies to many, many things that we do as personal physicians and medical homes for patients. So the case we started with a case, and here's a case of a 62-year-old coal miner, and I don't like reading long stuff, but I'm going to read this one. 62-year-old former coal miner wants to file for OP benefits, OP, Occupational Pneumoconiosis. The state program applies to occupational lung diseases, dust lung disease, other than coal mines. So it goes beyond coal dust exposure and any kind of occupational dust exposure. He stopped working in the mines on October 1st, 2016. He'd had a total of 24 years of occupational dust exposure as an underground miner, a prep plant operator, a boiler maker, construction worker. 14 years of that was underground coal mining. He smoked from age 15 to 46. So he quit. Let's see, 42, 40, at least 16 years ago with a 30-pack year cumulative history. And I said quit 20 years ago. He comes to the Black Lung Clinic for assistance in filing a state OP claim. And perhaps he was also wanting to file a federal claim as well. After the benefits counselor had finished with him and he got to the physician for his exam, the physician felt and recorded that his physical exam was normal. His chest x-ray is negative for occupational pneumoconiosis and shows only old healed fractures from a motorcycle accident. His spirometry and his lung volumes are normal. His DLCO, which is a study of gas diffusion in the lungs, is 76% of predicted. And the DLVA, which is a similar measure of diffusion, 76% of predicted as well. Despite his negative B-reader chest x-ray report and normal spirometry and lung volumes, the benefits counselor advises him to file for state OP benefits. The physician interviews, examines the miner, and signs the physician report, and there's a space on the report, which we will show you, the physician's part of the report. We have to put in a diagnosis, and the physician uses the diagnosis of coal dust exposure. Underneath that, there's about 3 more questions, or actually 4 more questions that the physician must answer on that form. Another one is actually a yes/no question. In your opinion, does this person have occupational pneumoconiosis? Yes or no? There, the physician put unknown. Then it says, how long has the minor had it? The physician put unknown. How much impairment does the person have? The physician put unknown. How severe is it? Physician put unknown. Next slide. Since 1968, West Virginia's had a legal process to compensate workers for lung impairment arising from occupational dust exposure. It is not limited to coal dust. This shows somebody cutting stone without a mask, without protection. And so this person could definitely be exposed to silica dust. Next slide. So now I'm going to turn it over to Susie, but Debbie Wills could just as well be doing this. And let her tell you kind of step by step what happens when a minor comes in wanting to file, because definitely in the Black Lung clinics, benefits counselor is an extremely important person, and always we are working as a team.
So first of all, when the minor contacts us, I talk with them on the phone to find out when they last worked, what their work history has been, and try to determine whether we should start with a federal claim or a state claim. If the minor is still working, it's usually advisable for them to do a state claim first. If they've stopped working around coal dust, then I usually have them file federal first because we can do a more extensive exam and get some better test results that we can use on the state claim. So I have them scheduled for an appointment. If we decide to do state first, I will schedule them initially for a chest x-ray and a breathing test. When they come in, we do those tests, but we also do an extensive history on them and fill out the claim forms. We schedule them back in usually 4 to 6 weeks. So it gives us time to get the chest x-ray back. I schedule them with the physician. Well, in our case, we use a nurse practitioner, and Dr. Doyle co-signs those claims. And the doctor sees them, does their part of the exam, and we talk to them about what to do after we do the claim. The deadlines portion is very important. If any way possible, we need to try to get the state claim in within 3 years. However, there's a loophole to that. If it's been more than 3 years, but they've never been truly diagnosed with black lung disease or occupational pneumoconiosis, we can get by that because the actual law says 3 years from the date of last exposure or 3 years from the date they were informed by a physician that they had occupational pneumoconiosis. So we do have that loophole that we can get them through even if they're more than 3 years out. Let's see. So do you want to go to the next, or you want me to explain the Pennington versus OIC?
Yeah.
Dr. Doyle? Okay. So in November of 2017, while we were enjoying Thanksgiving, we found out that our state had passed a new rule. So once we're past that 3 years from the date of last exposure, we now have to have documented impairment. And the physician has to be able to say on the forms that we have documented impairment that this minor or other occupation has diagnosed impairment due to occupational pneumoconiosis. So we had to go through a process of where we work, who our providers are, what they feel comfortable in saying is impairment, and to be able to put that diagnosis on the form. So we do have to have something out of abnormal range. We can use the FVC, the FEV1, the ratio. We can use DLVA because it's on the code guide, which you'll see a little later in the slides. They can have a positive chest x-ray, you can do a 6-minute walk test, but it all depends on the comfort level of your physician.
So before we change this slide, I just want to say, so the rule that Susie talked about in November 2017 was actually a West Virginia Supreme Court decision. And the Supreme Court decision was Pennington versus the Office of Insurance Commissioner. And as part of that Supreme Court decision, it became more difficult for minors to file. They put additional restrictions. So we could have done this talk 5 years ago, but it's a little different, and it's more important since 2017, November 2017, for providers to understand why precise language has to be used in their reports on these forms, period. So next slide. So then it gets to me and to Peter, and to Carl and to the providers to actually do this exam. And as working primary care providers, oftentimes we wish we had more sort of help or support. We wish we had more nurses to help us, more scribes. We have lots of things we'd love to delegate and don't get to do it. In this case, it's really wonderful to have a benefits counselor, because when I go in for that exam, everything is all filled out except just my part. Not only that, but over the years, the benefits counselor looks at what I wrote and checks for mistakes. And about 10% of the time, they would bring things back to me and say, you missed this, you missed that. Well, wait a minute, you have to write this exact language. Otherwise, this is just, there's no point in this person filing at all. So this is a situation where I get as much support as I could ever wish for, which is great. But still, when there is a patient, just like historically, used to be in the old days when we used paper charts, there'd be a paper chart hanging on the door or hanging in a box, and we'd pick the chart up and we'd flip through it to see, okay, if it's a new patient, who is this patient? What do I know about them? In other words, we prepare for the visit before the visit. And so in this case, what we should do, whether it's the day before or 5 minutes before, look at the history that's already been documented and their general medical history, because we're doing this in the medical home about half the time. About half the time, these are people referred to us where we're not their primary care provider or medical home. But review whatever it is that we have. Especially take note of their years of exposure. Who's their primary care provider? What does their chest x-ray show? What does their pulmonary function test show? Is their dyspnea level documented? And we use the MMRC dyspnea level, which is basically just a 0 to 4 level. And what's their smoking history? That's relevant. Really, really important is what is their date of last exposure? And in this case, that means their date of last exposure to occupational dust in whatever job. Because this has everything to do with the deadlines that Susie just talked about. Are they still working? In which case, no problem with being more than 3 years from date of last exposure. Have they stopped working, but their date of last exposure is less than 3 years? Or is their date of last exposure more than 3 years ago? The benefits counselor is watching this for us, but still it's good for us to be aware of it, because it will influence what we write in the diagnosis area. And then another really important question is, have they filed previously? Yes or no? Filed for state OP benefits, yes or no? And I only just learned this in the past month, that if they have filed previously, there are 3 potential outcomes of that. The OP board can find that they have no OP diagnosis, and therefore they have no award, no partial disability award. The OP board can find that they do have a diagnosis, but that they have 0 award. That can happen. And that's crucial because that marks that boundary line that Susie talked about, that at that point they have been informed that they have a diagnosis, and therefore the clock is ticking. The 3-year clock is ticking. And finally, in the old days, they could get a diagnosis with 5% or more impairment. That was eliminated. There's no more 5%. So now the lowest impairment award that you can get is 10% or more. But in the past, it had been 5. Next slide.
Dr. Doyle, I want to just get back to that for 1 second.
Should we go back to the slide?
Yes, please.
Okay.
So just to explain the difference between state and federal, under federal black lung rule, for the minor to qualify for benefits, they have to show total disability. Under state workers' comp, they just have to have some impairment. So they award percentages based on what level of impairment that they have. And that can be with or without a positive chest x-ray. So a lot of times I suggest to the minor to do federal first if they don't want to go back around the exposure, because they get some additional testing under the federal test that we don't do on state tests that may give them that additional edge in a state claim. So they do not have to show total disability on state, only impairment.
Right. And a point relevant to that is that the PPD, or partial permanent disability, of 10% or 15% or 20%, it's part of the same overall state workers' compensation system, which I think is pretty much similar throughout the country, that when you have an accident or an injury that leaves you with any kind of permanent impairment, even if it's the tip of your left little finger being amputated, potentially there is a whole system for assigning, for valuing that in terms of how much, quote, whole man impairment there is. So this fits into that general system. Okay, next slide. So then the next thing is that you go into the room and you talk to the minor and you perform a physical exam. And that physical exam is not an extensive, complete physical examination. That physical exam consists of sitting there and talking to the person and making all the observations that we make when we are just sitting there and talking to the person. So we're learning things about his or her neurologic exam, mental status, what language he speaks, and so forth. Is he moving both arms and legs as he walk into the room? Does he have oxygen on or not? Is he short of breath when he talks? So just that general appearance tells us a huge amount. We have vital signs, including resting oxygen saturation. We listen to we inspect and percuss and listen to auscultate the chest and the lungs. We listen to the heart and examine the heart. I always tell the medical students, don't come away with the bedside not knowing whether the person has a midsternal incision or not. So knowing whether there's a midsternal incision, which is an extremely common scar in Southern West Virginia in males, and also whether they have a pacemaker, but just those simple things. And then I always make a note of whether they have, I always look at their hands to note whether they have clubbing or not. And I always look at their ankles to see whether they have edema or not. And generally, I will ask the minor if he's had any operations, because when I fill out the workers' comp forms, I try to put something on the physical exam that would convince an OP board physician that I actually really examined the person. And I know that's terrible to think that those would be filled out without actually examining the person, but I wouldn't say that I've never done it, but a lot of weird things happen in medicine. And given that we can put an entire review of systems and an entire detailed physical exam into the record now with a single click of a button, it's not so far-fetched to think that exams that are never done are documented. So I try to put something in the record like a tattoo, a chest tube scar, an inguinal hernia scar that would suggest to the provider that I was really there. And then we document that. Next slide. And part of documenting that is to create a progress note in the permanent medical record. Even if we're not the PCP, still we do a full documentation, and I'm not going to read all this, but clinicians or attorneys or advocates, this is available to you. So what I did is I put what on this minor, this actual minor, I put what I did for his history of present illness, his past medical history, what I did for his physical exam, and what I did for his assessment and plan. And you can get back to that and use it if you need to, because Mitra and Elizabeth actually send out recordings of these. And if you could send out the PowerPoint, that would be easier for us than having to listen to a whole recording if we wanted to find it. So this is useful to coach a new physician in how to document the exam. And it's very relevant, by the way, because we bill commercial insurance for these exams. Susie made the point that she has people file for federal black lung first because you can get additional testing. When a minor applies for federal black lung, the Department of Labor pays for that exam. So that's not costing the minor anything. When a minor files for state black lung, that minor often has to pay for his chest x-ray, that often they have out-of-pocket costs. So that's a reason, another reason why we do the federal black lung exam first. But when we do these exams, we will bill commercial insurance. And so when you look here in the assessment and plan, we use a diagnosis of dyspnea on exertion. Because if we put a J6O diagnosis on a commercial insurance, they're just going to bounce it back to us and say, well, that's work related. We don't pay for that. So we don't put. So full disclosure here, we use a different diagnosis on the OP form than we use in the permanent medical record, and which I feel is perfectly legitimate to do. I do say in the medical record that I completed OP forms today, so it's not hidden what's going on with this exam, but in terms of filling out the billing forms, we use a different diagnosis. Next slide. Okay, and so then we complete and sign the physician report, and as we already told you, what diagnosis we use depends on where they are in relation to 3 years or less than 3 years of their date of last exposure. And we actually coined a new term, a new acronym specifically for this presentation. It's DIDTOP, D-I-D-T-O-P. DIDTOP stands for diagnosed impairment due to occupational pneumoconiosis. And it took a lot of coaching on the part, actually it was Lisa Emery here at New River Breathing Center, the respiratory therapist, to get this through my head, that I had to use this exact language. So next slide. So the form that the physician fills out is a 3-page form, although page 3 is really just a signature page, as you can see. And so the crucial parts of this form for the physician to fill out are the 3 that I've highlighted here. The highlighting in the middle page here, and you don't have to see the detail, you're zoomed out, and we're going to stay zoomed out. The second page is where you document the physical exam, and that's pretty straightforward. It looks just like any other form that you fill out would look like. And the signature is the signature. And this is everything else is filled out ahead of time for me. I look it over, I might make some additions, but the real crucial part is what's highlighted there about a quarter of the way down on the left-hand side, and we are going to zoom in on that. Next slide. So on this person, I'm sorry that the print is a little bit is poorly focused, but what it says right there is the date of the date of the exam or assessment. So I put in today's date. Then there it is, DIDTOP, diagnosed impairment due to occupational pneumoconiosis. And it's because in this case, this minor or this worker is more than 3 years beyond the date of his last exposure. Next question, in your opinion, has claimant contracted occupational pneumoconiosis? Yes or no? I always used to think that I had to check one of those boxes. But the benefits counselors told me, no, you don't have to do that. So I had always this big moral crisis. Okay, what is it? Yes or no? But they said, no, you don't have to do that. You can put possible or unknown. So that makes it easier. Next one, how long have they had it? Unknown. You don't have to necessarily fill an exact time. If they had a previous award, like a 10% award, say in 2014, you could put that. But what you put here is not crucial in terms of this claim being successful. And then, has the claimant's capacity for work been impaired by occupational pneumoconiosis? Well, if you put did top in the diagnosis, you gotta put yes. Because otherwise you're contradicting yourself, because the diagnosis says diagnosed impairment. So you can't come down here and put no, they're not impaired, because that creates a contradictory form. And then finally, to what extent? Generally, you can put mild, you could put unknown, but mild or moderate or severe, and that's very subjective in terms of the testing. But in theory, you could even put unknown here. So that is how you fill out this page 1. There are 5 lines here, 5 lines with 6 items. That's how you fill it out in someone who's more than 3 years beyond, where your clinical impression is that they do have a diagnosed impairment. Next slide. Here's what we would put for someone who is less than 3 years beyond their date of last exposure, and that's true for our case, the case that we presented today, because that person was less than 3 years. Also, that person had a normal X-ray, no pneumoconiosis on the X-ray, and had a normal breathing test except for the diffusion study. So this is the actual way we filled the form out in this case. It says, and this case was actually done in 2017. So on July 27, 2017 was the time. The diagnosis is coal dust exposure. One of the reasons, well, it's coal dust exposure. Then for the yes, no question, we put unknown, how long, unknown, to what extent, unknown, if yes, how much, unknown, and that was good enough to file this claim. Next slide. So I put here our little acronym, DID-TOP, diagnosed impairment due to, now, by the way, no one else has ever heard of DID-TOP until today except you. So don't expect that to be a universal term. You know, and Lori, don't expect it to be a universal term. If you want to introduce it, go ahead. But we try not to create too much local jargon, but every now and then we do. So anyway, so then the question is, we said that for this claim to be successful, they've got to have diagnosed impairment due to occupational pneumoconiosis. Well, how do you know if there's occupational pneumoconiosis, especially if the chest X-ray is negative? That gets to the fact that there is a difference between clinical pneumoconiosis and legal pneumoconiosis. And this is really, really hard for physicians, because we are trained that diseases are defined clinically, not legally. And so it's very difficult for us to understand how you're going to diagnose pneumoconiosis with a negative chest X-ray. So how do you know, for the purpose of this exam and this form, if you can honestly, truthfully say that this person has occupational pneumoconiosis? Well, the easiest is if they do have a positive chest X-ray. But legal pneumoconiosis does not require positive chest X-ray. Next slide. Now here's a very detailed slide that you can come back and study. If you know, Laura, you might want to do this. Debbie Wills probably knows it by heart, and Susie. But this is a good source from Cornell Law School, citing federal code about the definition of clinical and legal pneumoconiosis. And for legal pneumoconiosis, which is what this form is about, it does not require a positive chest X-ray, B-reader chest X-ray. This is a whole bunch of words, a lot of verbiage, legalese, but I boiled it down to this simple definition. Next slide. A simple approach is clinical pneumoconiosis is history of exposure, because you got to have exposure. We're not going to diagnose pneumoconiosis in somebody who was a cab driver their whole life. So that they have worked in, unless they were a cab driver out to, you know, an open pit mine or something. And we do sometimes file claims for people who have been only truck drivers, but they've had a lot of dust exposure. So clinical pneumoconiosis, a history of exposure plus a positive B-reader chest x-ray with a 1/0 or greater. And that gets to what do these B-reader reports look like. Legal could be history exposure, negative chest x-ray, but symptoms like dyspnea, cough, physical exam findings, pulmonary function test findings, blood gas evidence of impairment. So if they've got that history of exposure, and for me, the more years, the less tobacco, the higher my comfort level in diagnosing pneumoconiosis in the absence of a positive chest x-ray. Next slide. It's really important that our physicians, and especially pulmonary medicine physicians, know what an ILO B-reader report looks like. And generally what we get is whenever there is a B-reader report, the B-reader fills out this form on the left that has the yellow highlighting on it. Sometimes, often, we get the kind of narrative report that we're used to along with it. But we have, one of our best B-readers only gives us the sheet over here. She doesn't do the narrative report. She just fills out the ILO form. The parts I've highlighted is where I look the first. And I'm not going to zoom this and go into it, but if you're looking at one of these B-reader reports, and you will see them, I recommend that you especially look at the highlighted part. This little box right here, and they probably can't see my cursor, can they, Mitra?
No, I do not believe so, Dr. Doyle.
Okay. Can you get a cursor on there?
Let me try. Can you guys see this?
Yeah, so see that little thing that looks like a two-dimensional Rubik cube there, that little stack of blocks? Right, yeah, right there. Okay, that is a 0 to 12 scale of how much dust you have, dust scarring you have in your lungs. So look at that. And then just to the right of that on the screen, Mitra, that row of 4 boxes is where whether there is complicated pneumoconiosis or not is indicated, and that's really important. And then at the very bottom, that long strip, what that says is, are there findings on this x-ray that make it important to communicate with the primary care physician? So if you're the examining physician and you're seeing this B-reader form, it's really important to look at the stack of blocks up there, because that gives you an extent. And if you jump over to the narrative report, Mitra, and see where it says impression, and just below that, if you have microscope vision, it says simple pneumoconiosis category 2/1. That 2/1 comes off that stack of blocks on the left side, and you can see that that box has actually got a little check mark in it. So that's important. So the B-reader form, if you're an examining physician, learn how to look at this, and this is a help. And if you're a benefits counselor, you're going to want examiners who know what this means, knows how to look at it. And then, even if this person is coming from a different primary care physician, if something shows up on this x-ray, because the B-reader looks at all aspects of the chest x-ray, and it's common for there to be masses, it's common for there to be atelectasis, it's common for there to be enlarged hilar nodes, and that's what they note at the bottom there. So we have a responsibility, and Dr. Wernz does this all the time with his federal black lung exams, of making sure that serendipitous findings, but clinically significant findings, are addressed and followed up, either by us or communicating with the primary care physician. Next slide. Okay, so I just talked about if you're the examining physician, how do you know if they have occupational pneumoconiosis by legal definition if their chest x-ray is negative. Okay, so now you've convinced yourself of that, but then where do you get diagnosed impairment? So there's two parts to DIDTOP, the diagnosis of pneumoconiosis and the diagnosed impairment. Well, like I said already, you consider their years of exposure, their symptoms, and their testing results. And we refer to the Table 8520 in the West Virginia Code of State Rules for Workers' Compensation. Next slide. And this is what that looks like. Title 85, the Exempt Legislative Rule, the Workers' Compensation Commission, Series 20, Medical Management of Claims Guidelines for Impairment Evaluation. So this table just applies for occupational pneumoconiosis, but it's taken out of the West Virginia Workers' Compensation rules that addresses all different kinds of impairments, including losing the tip of your little finger, or having a blown knee or a blown shoulder or a bad back. And so this table is what we look at. These are the rules that compensation gives us. So at the very bottom there, it shows DLVA, which goes along with DLCO, and what levels they will award for. So Table 8520, really, really important in knowing whether they have diagnosed impairment or not. Next slide. So then I'm going to, actually, we're going to come back to this slide, but just jump forward, Mitra. Let me see what else I gave you here. Keep going. Keep going. Okay, so let's go to this slide, the last slide. Okay, and then we'll jump back. So Susie, I would like for you to talk about the history of how this claim proceeded, and you can use you can just ask Mitra to bounce back and forth. So here over time, because we are again dealing with this claimant now, and he's getting ready to refile. And Susie's going to talk about what that is and why he would do it. And this is the sequential testing data for that, Susie. But if you go back a slide, Mitra. Okay, we've already looked at this. Back one more slide. I put it in there twice. Here you've got his award letter. And I think I might let you, I'll go back one more. Okay, so Susie, you got 4 slides to work with. The reopening, which might come last, the award letter, and then his sequential testing data. So go for it.
Okay, so this minor initially came to me in 2017. He had recently retired from work. He did not plan to go back to work around dust. We did a state claim. I think we initially did a federal claim and had test results from that, and then did his state claim. He filed, and it took about a year. It's important to note that on these workers' compensation claims for OP, they're not like any other workers' comp claim. When we file these claims, and we generally advise them to use an attorney on these claims, this entire process takes at least a year. Their claim will be processed to make sure, first of all, that they have enough exposure to file, that they meet the criteria. Then it's eventually referred to the OP board for an exam, and they're kind of backed up on their testing. They eventually get their testing, and then it takes the OP board another few months to make a decision. So this minor filed in 2017. And you can go to that results page. Let's see, the next one, I think. Nope, I go down to right there. Okay, so in June of 2017, he had pretty good numbers. His ratio, according to national standards, is pretty good. His FEC is 107%, 106% on the FEV1. His DLCO is just a little bit below normal. 80 and above is generally considered pretty good. But he was at 76% on his DLCO and his DLVA. So we filed his claim, but in this claim, we wouldn't have needed anything out of normal range to file because he was within 3 years of his date of last exposure. In February of 2018, he got his decision and he was awarded 10%. So he brought the papers to me. They don't send those copies to us. So I always advise the minor to bring those award letters back into us. He brought this in, and this starts a new deadline for us. So since he was awarded 10%, and it was most likely awarded based on that DLCO and DLVA, go up to the chart that we had with the West Virginia code. So under this code, at the very bottom where it says DLVA impairment, 60 to 79% would award the minor a 10 to 20% impairment. He got 10%. They do generally take into consideration if they've had a smoking history, and will sometimes alter their award percentages based off of that. I've seen them take 5% away based on the minor's smoking history. But he was awarded 10%. So from this date of award, which is February 19th of 2018, we now have 5 years to reopen this claim. So I always advise the minor, come in every year and have a breathing test. We need to see if your numbers are worsening. And in order for me to reopen these claims, they have to show additional impairment. So those numbers would have to drop so that I can prove at least a 15% impairment award in order for me to reopen it. So that started our clock on that. He was just here this year, and his breathing test this year did show enough impairment for us to refile the claim. So on July 14th, we did a reopen claim on him. Let's see, go back to the last slide, which is the comparing of his test results right here. Okay, so his DLVA at the very bottom had dropped from 76 in 2017 to 45 in 2021. So this is a substantial drop in his impairment. But
Can I jump in here for a second?
Sure.
Okay, so again, clinicians, Peter, well, Dr. Weissman knows all this. But Benedict Kane and Joseph Orlando and Carl kind of knows this, that there's two things on this slide right here that to me are really important. One of them is another thing that's really hard for physicians is to understand, and it was hard for me for a long time. Why would we think that someone be awarded compensation for lung disease if they have a normal chest x-ray and a normal breathing test? Like, wait a minute. And it took me a while, even though I knew about federal black lung exercise blood gas testing, and I'd been mentored by Don Rasmussen when I first came here. Still, I just had this in my head. Well, their x-ray is normal, their breathing test they're normal, their spirometry is normal. And this is a good example of the rules compensate someone. And so the minor's attitude is, well, if that's the law and I'm entitled to this, I want to get it. They always will say to you, I'd rather not have lung disease, but if there's something that I'm entitled to, I feel like I should get it. And so this was an example of somebody who normal chest x-ray, normal breathing test, but significant diffusion impairment based on the law. Another really interesting thing for me about this, and it was encouraging, is that I don't understand why they repeat all the same tests when people go to the OP board in Charleston, but that's how West Virginia does it. I don't think all states do it that way. But what you're seeing on June 9th, 2017, you're seeing our testing, and on January 4th, 2018, the OP board testing, and it was very encouraging to me to see that they're nearly identical. So that's great reproducibility at two different sites, in my opinion. And then the third thing about this is that 3 years later, it actually looks like his spirometry is better, but probably not significantly different. But that there is, it looks like significant drop in diffusion capacity. So characterizing lung impairment is a tricky business, and it's not a one test thing, like say using an A1C for diabetes control or a hemoglobin for anemia. It's more complex. Go ahead, Susie. You're muted, Susie.
Sorry about that. This particular miner, he has, since retirement, remained extremely active. Unlike a lot of other people who, you know, have a little bit of decline because of inactivity, this miner runs every day at a track. So that would also maybe account for some of the improvement in some of his numbers. This could be a whole different story if he weren't doing that. We did refile his claim in July for a reopen. That form, Mithra, if it's okay, could you go back up? I'm not sure where the slide was.
One more.
One more. Yeah, so this is a reopen claim form. So on the bottom of that, you can see that the 10% occupational pneumoconiosis, that was what he was previously awarded. On number 10 is the really important part to get him reopened. We have to fill this out so that we can demonstrate worsening in his breathing. So he had previously got a 10% award. His DLVA of 45 now and a DLCO of 67 shows a decrease, and he should be entitled to reopen. What will happen now is this claim goes back to the attorney that I got him on the first part of the claim. They will submit it to the third-party insurance company, most likely HealthSmart or Smart Casualty or AIG, and they will process the claim. If it looks like he's entitled to reopen this claim, they'll send him back to the OP board for another exam. They don't always take our word for it. They want to do their own testing, and the reopens typically go a little quicker than the initial files. So in an initial file case, it would generally take about a year, but the reopens usually are done before 6 months.
Thank you, Susie. I'm sorry we took up almost all the time because I know there are people here who have comments and maybe questions. And so, Mitra, I'll leave it up to you when you have to pull the plug.
Absolutely, no worries. We do have about 4 to 5 minutes left here, and we wanted to do a quick poll at the end of today's session as well, just to get everyone's feedback from the session. So, but please do take it away. If there are any questions for Dr. Doyle or Susie about the PowerPoint or their cases, please unmute and ask away. And this is a safe space for everyone to chime in. Dr. Wertz?
Sure, I'll just ask a quick question, which is in the, I'll do this so you guys can actually see me. In you used the federal definition for legal pneumoconiosis in your talk, and I don't know if we have any of the attorneys on. I see it's Joan Klein, not John Klein, so that may not be the same person. But I'd be curious, where does the West Virginia definition, does anybody know where the West Virginia definition of legal pneumoconiosis is found in writing, or is it just a series of court decisions rather than any one particular definition like we have on the federal side?
I think that the PowerPoint slide that Dr. Doyle used on the legal versus clinical was taken from the West Virginia Workers' Compensation Code book. And we did get input from Maroney, Williams, Weaver, and Pancake.
Susie, I actually think that Cornell law slide is referring to federal, not
Okay.
West Virginia state. So if it exists, Carl, I've never seen it. And I'm sort of blocking on the word for this, but I think we're looking upon state OP applications and federal OP applications as parallel processes, and we're applying the federal over to the state until someone tells us or shows us something different, which we often do in medicine, sometimes with good validity and sometimes not. But till they give us something, this is what we're using.
I do have the presumption language, and I can send that to you.
Well, could you say what that is?
So the presumption language in West Virginia Code comes from, if it can be shown that the minor or deceased employee has been exposed to the hazard of inhaling minute particles of dust in the course and resulting from his or her employment for a period of 10 years during the 15 years immediately preceding the date of his or her last exposure to such hazard, and that the claimant or deceased employee has sustained a chronic respiratory disability, it shall be presumed that the claimant is suffering or the deceased employee was suffering at the time of his or her death from occupational pneumoconiosis, which arose out of the course of employment. The presumption is not conclusive, but this is where it takes into the account the difference between the legal and clinical.
And Susie, if you would like, you can email me any resources that you want to share with the group, and I'll make sure to have it in the recap.
Okay, and you know, before we quit today, I just wanted to tell Dr. Wenzel, you know, you have an excellent resource with Preston Taylor. Amy Livengood is an excellent benefits counselor. I've worked with her for years. Use her. She will help you guys. She will do what's best for the minor for sure.
No, I've been working with Amy for what, 15 years now. She's always been great. So no,
Yeah.
we're lucky to have her.
I want to speak in one last thing, Mitra, and that is that sometimes there are times, you know, the benefits counselor's job is to help the minor take advantage of any possible opportunity to get benefits. Their job is advocacy. Our job is examination. And there are times when we can't say did top in our, you know, to the best of our knowledge. And that can be a big disappointment for the minor. And that can sometimes be a disappointment for our colleague, the benefits counselor. And when that is the case, we have to be willing to say, I'm sorry, I don't have it, and not put did top and not sign the form. That's rare, but it does happen, and it's difficult. It's one of those difficult conversations in medicine, but there are such times. And if we had another half hour, we would role play one of those conversations, but we don't.
I know, Dr. Doyle, I always wish these sessions were a little longer than 1 hour. Absolutely. Well, I wanted to get into a couple announcements and then launch the poll, but were there any final thoughts or comments that anyone wanted to share with the group?
So this is David. I just wanted to throw out one thing, which is that it's really well documented in the literature that CT is much more sensitive for pneumoconiosis than chest X-ray. And I know that, finances and access to, to healthcare is an issue, but often minors may qualify, for, like low dose CT for lung cancer screening, which is cheaper. And so if you have people who have heavy exposure history,